Welcome to HCV screening and treatment for the male patient. To receive continuing education credit for this activity, you must take the pre and post test. Both the pre and post test links can be found in the video description below. Please be sure to take the pre-test before viewing this video. In 4 weeks, you will receive an email from ARHP's Education Department with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you've incorporated what you learned during this webinar into your work. Completing the pre and post test, as well as this follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce our faculty, Drs. Jenna Kawamoto and Austin Nation. Dr. Jenna Kawamoto is a clinical pharmacy specialist at the VA Greater Los Angeles Healthcare Center, or VAGLA. Dr. Kawamoto earned her Doctor of Pharmacy degree at Creighton University in Omaha, Nebraska. She completed a PGY1 pharmacy practice residency at the VA in Roseburg, Oregon, and then completed a PGY2 fellowship in gastroenterology, hepatology at the VAGLA. Dr. Kawamoto has been involved in all steps of hepatitis C care, including screening, referral, evaluation, treatment, and follow-up care. She serves as a preceptor for rotational and PGY1 pharmacy residents. Dr. Austin Nation is a graduate of the University of California, San Francisco School of Nursing. Dr. Nation completed his Master of Science in Nursing with an emphasis in leadership and education from California State University, Fullerton. He has been a nurse for over 30 years and is currently an assistant professor at California State University, Fullerton. His research interest is with understanding substance use and HIV among young Black men who have sex with men, funded by the Substance Abuse Mental Health Services Administration and American Nurses Association Minority Fellowship Program. Dr. Nation was also a fellow in the Black AIDS Institute's African American HIV University Science and Treatment College. He has been doing HIV prevention education for over 15 years. We're thrilled to have them with us today, and without further ado, I will hand it over to Austin.
Great, thank you very much. So before we get started, I just want to say that this project and webinar is being funded through an independent educational grant from Gilead. So we want to thank Gilead. None of the planning committee has any kind of disclosures that we want to acknowledge. And so let's look at our learning objectives for this particular session. There are several of them here. The first one is that we identify key patient populations at risk for hepatitis C infection and implement screening strategies to detect and treat hepatitis C. We want to be able to communicate with patients about the importance of Hep C screening, as well as implications of initial positive antibody results, and effectively describe the treatment options and long-term outcomes. In addition, we want to recognize common comorbidities and unique patient populations who will benefit from additional counseling and treatment regimen modifications. We want to then apply techniques and tips to counsel male patients on the updated HCV screening guidelines and preventative measures. And then we're going to also discuss a few barriers pertinent to Hep C management, including treatment access and cost adherence, and a little bit about reinfection. So, in looking at our intro to this topic around hepatitis, we want to start by just defining what is hepatitis. And simply described, hepatitis is liver inflammation. The most common form of hepatitis is viral hepatitis caused by hepatitis A, B, C, or D viruses. Each virus has a different pathophysiology resulting in distinct signs and symptoms. The most common form of viral hepatitis is caused by hepatitis C. Hepatitis C is an RNA virus from the flavivirus family and is the most common cause of chronic liver disease and cirrhosis in the United States. Hepatitis C is primarily transmitted by blood, but it can also be transmitted by sexual contact or perinatally. So when talking about the pathology of Hep C, stages of Hep C infection can be categorized as either acute, which is less than 6 months after infection, and chronic, which is persistence more than 6 months after infection. Both stages are usually symptomatic, and that presents some challenges. Fewer than 25% of people acutely infected have signs and symptoms. Most are nonspecific, such as fatigue, nausea, headache, and abdominal pain. Some patients will present with jaundice, but by and large, most patients are asymptomatic. Most patients also fail to clear the virus, making chronic infections common. Chronic infections lead to continuous liver damage, which can result in cirrhosis, hepatocellular carcinoma, liver failure, and/or extrahepatic manifestations. In looking at the natural history of Hep C infection, after exposure, the disease progresses slowly, usually over about 20 or 30 years, depending on the presence of various risk factors. Some will spontaneously resolve the acute infection. And then of those who get the chronic infection, approximately 20% develop cirrhosis, and 25% of those go on to develop hepatocellular carcinoma or require some type of transplant or death. In terms of epidemiology, the National Health and Nutrition Examination Survey looked at data between 2003 and 2010. And these are used for estimating HCV prevalence, but they really fail to account for incarcerated and homeless populations, leading to oftentimes an underestimation. When including incarcerated and homeless populations, 4.6 million are antibody positive and 3.5 million are chronically infected, as evidenced by a Hep C RNA test. Demographically, we're talking people between the ages of 40 to 59, which are our baby boomers, and they're the ones most likely to have Hep C infections. When the general population demographics are considered, Hep C prevalence is higher among Hispanic and Black populations. So let's talk a little bit about screening for Hep C and what that means. So we're going to start with a case presentation. And we have Joe here, who is a 50-year-old African-American male who is visiting his primary care provider for persistent cough. He's diabetic, overweight, and he's also a smoker. For 6 months, Joe was incarcerated. During his time in prison, he received an unregulated tattoo. So how would you evaluate Joe? And we'll talk about that as we move through our presentation. So the new screening guidelines have come out, and these are because the treatments available for Hep C are now curative, effective, and safe. It's important that we treat as many people as possible of these chronic Hep C infections. Ultimately, this will help reduce transmission of the virus. The Centers for Disease Control, the U.S. Preventative Services Task Force, the American Association for the Study of Liver Diseases, and the Infectious Disease Society of America have all recommended both birth cohort screening and risk-based screening. And these guidelines have all come out within the past 5 years. So things have really dramatically changed in recent years in terms of how we go about screening people for hepatitis, as well as the new treatments. So in terms of both birth cohort, baby boomers, as I referenced, these are adults born between 1945 and 1965, and they should be tested once for Hep C, regardless of any other kind of risk factors. This is because the vast majority, 75% of these individuals infected with Hep C were born during this time. Furthermore, Hep C-related morbidity and mortality are higher in this population than in other age groups. Because of the potential to prevent disease progression, there's a good cost benefit for just simply one-time testing. So we want to get all these people tested at least one time. And the rationale for this screening is because Hep C is asymptomatic most of the time, and many people don't even know that they're infected. Risk-based screening alone fails to identify all patients with chronic Hep C. birth cohort screening identifies many asymptomatic cases, averting more than 200,000 cases of cirrhosis and more than 120,000 deaths due to undiagnosed Hep C. So these are powerful numbers in terms of the lives that can be saved by these screening measures. Risk factors warranting screening for Hep C. So outside of baby boomers, many other populations may need one-time or regular screening dependent on the frequency of exposure to the risk. Those who are previous or current patients who have injected or inject drugs should be screened once if they are abstinents or regularly if they are continual users. Recipients of clotting factors concentrated prior to 1987 and recipients of transfusions or transplants prior to 1992 should be screened once as well. We also want to screen HIV positive individuals at least once. And also those who have persistently abnormal aniline transferase levels should also be screened. In addition, many of the organizations that I mentioned previously further recommend that intranasal drug users receive testing as they are at elevated risk. Additionally, they recommend that those who receive unregulated tattoos be tested at least once. And you can think about Joe from our case presentation who got an unregulated tattoo. Other key populations include men who have sex with men. And men who have sex with men are at a higher risk for hepatitis C infection. In part, this is due to the high prevalence of HIV infection in this population, which weakens the immune system and increases the likelihood of infection. Female partners of men who have sex with men may also be screened. Although the risk for sexual transmission may be low, it is not impossible and has been observed. Importantly, the lower the HIV-infected individual CD4 T cell count, the higher the likelihood that this individual will have hepatitis C. Other key populations are heterosexual partners of those who have hepatitis C. And this is since hepatitis C is a blood-borne pathogen and blood contact is the primary mode of transmission. Sexual transmission can occur in heterosexual monogamous couples. This is a rare but important risk with transmission rates at 0.07% per year. Transmission may not be associated with specific sexual practices, but little high-quality research has been done on this subject. So these are possible candidates for at least an annual screening. In terms of rising Hep C related mortality, Hep C infected populations, as Hep C populations age, the slow progressive nature of Hep C infection is leading to rising morbidity and mortality. And again, between 2003 and 2013, the Hep C related mortality increased by 6.2% per year, surpassing 60 other nationally notifiable diseases, which decreased by 3.4% that same year. So things like HIV, Staph aureus, Hep B, TB, and pneumococcal. And the thing with this is because Hep C is symptomatic. So the authors noted that in particular, that this was also caused by lack of screening and treatment, as well as difficult to treat patient populations, such as those that are co-infected and also those that are non-responders. It's important to also talk about the evidence-based 3 to 5 year reinfection risk. In 2014, there was a meta-analysis of reinfection risk that revealed that it was relatively low in most populations, but it did increase among increasing exposure to risk, such as IV drug users and co-infected individuals who may engage in high-risk behavior. So in other words, most people are not at risk for getting reinfected, except in these special populations. And let's talk about underdiagnosed populations. So when we're talking in general, hepatitis C has a prevalence of about 1% in the general population. The prevalence is much higher in many other populations, yet these individuals are often likely to go undiagnosed. HIV prevalence is highest among the homeless population at 32%. HCV is also high among the incarcerated population. You can think about Joe again from our case presentation, as well as those Native Americans living on reservations. Furthermore, it's important to note that birth cohort may not have as much impact in terms of risk in these populations. Hep C is common even in people born after 1965 in these underdiagnosed populations. So we want to pay extra attention to these different groups. In terms of patient awareness about hepatitis C, and this was interesting, and this to me is really where the heart of this work really lies and where it's really important. Overall, there's just a poor awareness of hepatitis C due to the asymptomatic nature of the disease. And this is particularly true among baby boomers. The low awareness of the disease may decrease screening rates. When surveyed, only 51% of baby boomers knew that Hep C was curable, and only 17% knew there was no vaccine. Just over a quarter were aware that they were at higher risk than the general population. Patients were also unaware of the modes of transmission for hepatitis C. So much work here to be done in this area. Clinician counseling and achieving screening goals. Clinician counseling of patients is an important step in achieving our screening goals. When visiting with patients who were born between 1945 and 65, or patients with high risk factors, clinicians should initiate conversations about testing. Improving knowledge about Hep C complications such as liver failure increases the willingness to be tested. Improving knowledge that Hep C is curable and has new effective treatments increases the willingness to be tested. And this oftentimes makes me think that there are a lot of people that still think that the only treatment available for Hep C is the old interferon treatment. Many people are not aware that there is a new, simpler medication treatment, the 3-month, 12-month oral pill regimen that we'll talk about a little later. So yeah, we really have some work in terms of getting that information out to folks and encouraging them to get screened. So when we're looking at the testing sequence, we're going to start with the antibody test. All diagnoses begin with an anti-Hep C antibody test. So there's 2 tracks. Basically, if the test is negative, non-reactive, no HCV antibody has been detected, you can stop there. But for those that have been exposed in the last 6 months, or for those with immunocompromised individuals, you may want to consider further testing. And that's because on the other side of the chart, if you have people who are also Hep C antibody positive, this indicates that the person at one time had Hep C, but it was possible that it resolved. To test for chronic infections, the clinician must proceed to the next part of this screening process, which is having them do a Hep C RNA test. And so when we're looking at the RNA test, again, there's kind of 2 sides to this chart. If the RNA test is negative, then there's no current Hep C infection. However, on the other side, if it is detected, then you want to immediately link these individuals into care, because these positive test results indicate that there was a chronic Hep C infection underlying, and we want to get moving on that. Standards in care for Hep C. We have one goal, and that is for Hep C treatment, we want to have sustained virologic response. And this is typically indicative of a cure after the 12-week treatment. The other goal is to prevent progression to cirrhosis. These goals can be achieved by using new direct-acting antivirals, which have led to a paradigm shift in the way treatment of Hep C is approached. Direct-acting antivirals target viral proteins, making it impossible for the virus to replicate. So who should be treated? In short, everyone with Hep C, chronic Hep C infection should be treated. There's this common misconception that only certain patients with chronic Hep C should be treated, where in reality, the guidelines clearly recommend treatment for virtually all patients with Hep C. The only excluded patients are those who will not benefit due to short life expectancies. So now my colleague Jenna will talk about the specific drug therapies for Hep C. So take it away, Jenna.
All right, thank you, Austin. So I'll be giving a brief overview of the various oral direct-acting antiviral agents, or DAAs, that we currently use to treat hepatitis C. Let's start with Harvoni, or ledipasvir sofosbuvir. Because it is effective in multiple genotypes, including the genotype most common in the United States, which is genotype 1, Harvoni is often the first choice for many physicians. Approved in 2014, Harvoni was one of the first combination second-generation DAAs that was approved and targets both the NS5A and NS5B polymerase. SVR rates are consistently at or above 95% in clinical trials, and recent real-world data indicates that the SVR rate does not fall by much without the strict clinical trial environment. Harvoni is costly, however, at $1,125 per pill, leading to a bill of about $94,500 for the usual 12 weeks of treatment. However, in a recent analysis of cost effectiveness, Harvoni was far more cost effective than traditional interferon-based treatments in terms of cost per SVR and cost per quality adjusted life year gains. Harvoni was also more cost effective than other DAAs that were analyzed. Epclusa, or sofosbuvir velpatasvir, is the first pan-genotypic DAA approved by the FDA. Like Harvoni, Epclusa targets the NS5B and NS5A polymerase. The SVR rates are very good in clinical trials, even for the tough-to-treat genotype 3. Real-world effectiveness data, however, is not yet available. And the cost is comparable to, or even slightly less than, currently available DAAs at $890 per pill. Vicira Pack is a twice-daily multi-pack pill. Vicira XR is a once-daily multi-pack pill. Ombidavir, paritaprevir, and ritonavir are all in a single pill, and dasabuvir is in a single pill. Ritonavir does not have activity against the Hep C virus, but it's used in there for a CYP3A4 inhibitor and is included in the regimen to improve the pharmacokinetics of paritaprevir. Vicira is approved for genotype 1. The SVR rate for Vicira is high for genotype 1B at 100%. However, it's slightly lower for genotype 1A and should be administered with ribavirin, usually twice daily. And also ribavirin comes with more side effects. The cost is comparable to other HCV treatments, and at least one cost-effectiveness study has indicated that the high SVR rate and improved quality of life year adjusted may make Vicira favorable to Harvoni in patients with genotype 1. The next drug, Zapatir or elbasvir brazopavir, is approved combination drug for genotypes 1 and 4. This drug targets the NS5B polymerase and NS3-4A protease. It has similar efficacy rates as other drugs, but the cost sets it apart. At only $54,600 for a 12-week treatment, the price point is well below that of Harvoni, Epclusa, or Vicira. Although cost-effectiveness studies have not yet been done, since this drug has similar SVR as others, cost-effectiveness will likely be established as favorable. Alisio or Sameprovir is a NS3-4A protease inhibitor, and Sovaldi or Sofosbuvir is an NS5B polymerase inhibitor, and they're two separate drugs. The combination of Sameprovir and Sofosbuvir is used for patients with genotype 1, and the SVR rates are lower than those seen for other combination treatments, and the cost is also much higher. While it's more cost-effective than Sofosbuvir with ribavirin, it's still less cost-effective than Harvoni. Decladovir or Declenza is an NS5A protease inhibitor, and Sofosbuvir again is an NS5B polymerase inhibitor, and they're used in combination and approved for genotypes 1 and 3. It can also be used off-label for genotype 2. The SVR rates are good, even for the difficult to treat genotype 3. However, it's very expensive and has a low cost effectiveness compared with other treatments. Now, when evaluating patients for treatment, clinicians should discuss certain topics with their patients. Everyone with HCV should abstain from alcohol to protect liver health, as alcohol worsens hepatic comorbidities in patients with HCV. Clinicians should be also prepared to counsel patients on alcohol abstinence and recommend treatment programs when necessary. Importantly to note, however, alcohol use does not decrease SVR rates and is not an evidence-based reason to withhold treatment. Nonetheless, clinicians should be aware that Medicaid and other insurances may require alcohol abstinence for reimbursement. Because of shared modes of transmission and overlapping risk factors, patients with HCV often have other viral infections. Both hepatitis B virus and HIV are associated with poor HCV prognosis. Clinicians should evaluate patients for co-infections and manage any that are found. Now, once a patient tests positive for HCV, clinicians are responsible for educating the patients on the transmission of HCV. For most patients, transmission should focus on the potential for blood contact. This is especially the case for intravenous drug users, who should be counseled on the best ways to reduce injection-related HCV risk. Examples include sterile equipment or rinsing syringes with bleach if possible. For men who have sex with men, clinicians should counsel patients about safe sex practices. And for if you want to read more resources on this, the website is listed here. Now, before selecting treatment, patients should be evaluated for liver fibrosis and staged. This will facilitate treatment decisions and also allow clinicians to select patients at the highest need for treatment in resource-limited settings. Also listed here are some predictors of severe liver fibrosis. So if that greater than 40 years of age at time of infection, if a patient consumes more than 50 grams of alcohol per day, the CD4 T cell count is less than 500, daily marijuana use, and postmenopausal status are all predictors of more advanced fibrosis. Liver biopsy is the gold standard for fibrosis staging, but it is invasive and carries associated risk. Even in ideal conditions, more than 20% of patients are incorrectly staged. Now, liver biopsy is mainly used when inconsistent results are achieved, when non-invasive tests, or when determining whether patients should be screened for HCC. Many non-invasive staging tests are available that are relatively effective in determining the stage of liver fibrosis, such as the APRI and FIB-4 score, which is basically a calculation that incorporates the patient's specific age and lab. There's also transient elastography, such as a fibroscan to measure liver stiffness. And other radiological methods are ultrasound, CT, or MRI. Some insurances, however, still require invasive staging prior to agreeing to treatment, even though the ASLD-IDSA recommendations indicate that patients in early stages of fibrosis should be treated, so non-invasive staging should suffice. There are barriers, unfortunately, to the standard of care. One of the main barriers is cost. Uninsured patients are likely to be unable to afford treatment with DAAs due to prohibitive costs. Even among insured patients, reimbursements may be limited by non-evidence-based factors. Examples include alcohol abstinence, which has no effect on SVR outcomes, invasive fibrosis staging when non-invasive methods are sufficient, and no injection drug use for at least 6 months, but SVR is possible even with the occasional drug use. Additionally, some insurances only allow one lifetime treatment. So if a patient is reinfected, they cannot receive another round of treatment. Still, cost-effectiveness analysis indicate that DAAs are the most cost-effective choice of treatment when considering SVR and quality of life years gained. Another barrier to care is socioeconomic status and race. Black patients and Hispanic patients are at higher risk of HCV infection, but are less likely to receive treatment. Hispanic patients had the highest rate of cirrhosis and the second lowest rate of treatment in one study. Black patients are often not given the option for treatment, as one study found that 40% of patients were deemed treatment ineligible compared with 20% of white patients. Reasons for ineligibility that disproportionately affected Black patients included abnormal hematological values, abnormal chemistry values, poorly controlled diabetes, and pre-existing medical conditions. Black patients were also likely to be lost to follow-up. And another study also found that socioeconomic status is also negatively correlated with likelihood of receiving treatment. Patients may not be adhering to treatment due to duration and cost. This is probably in part why real-world data indicates SVR rates are lower than clinical trial data. Therefore, clinicians are responsible for engaging and educating patients, which will increase the adherence level. For more patient engagement resources, here's the website, a great website to go to, www.prepc.org. Provider-driven reasons can also be a barrier to care. Many clinicians are unwilling to treat patients who inject drugs or have not been abstinent for 12 months against evidence-based guidelines. Indeed, almost half of all providers will not treat intravenous drug users even after 12 months or more of abstinence. Studies have shown reinfection can occur after SVR in drug users, but has very low incidence. And SVR is even achievable in patients who concurrently inject drugs. Now, let's go back to our patient, Joe. Although Joe is not a baby boomer, his history of intravenous drug use and time spent incarcerated are both risk factors for HCV. Therefore, Joe should be counseled on the risk for HCV, the potential morbidity and mortality of the disease, and the curable nature of the disease. Joe should be offered HCV antibody screening and explain that if the test is positive, he will need additional screening. You reassure Joe that a positive test allows you to treat the disease and likely eliminate it. So we do a blood test on Joe. His antibody returns positive for anti-HCV and for HCV RNA. Next, he should be genotyped, evaluated for the extent of liver disease, which includes further lab tests, imaging, or liver biopsy. Joe should also be screened for HIV as well with his consent at this time. After Joe considers all this, we get all the workup done, then Joe should be started on a DAA regimen and counseled on the importance of adherence to treatment to have the best chances of cure or SVR. Now, we'll talk a little about common comorbidities associated with HCV and special patient populations. HCV is often accompanied by hepatic comorbidities. One of these is non-alcoholic fatty liver disease, or NAFLD, which is a result of a metabolic disorder. Another is hepatocellular carcinoma, which is likely due to cirrhosis. Several extrahepatic comorbidities are associated with HCV. Connective tissue disease, depressive disease, esophageal disorders, and diabetes are all at higher prevalence in the HCV-infected population than the uninfected population. There are other manifestations as well. It is important to note that it can be difficult to tease out these comorbidities of HCV and comorbidities related to treatment with interferon or ribavirin. In the future, data from the population of patients treated with DAAs will be useful. Now, treatment is not always straightforward, and there are special populations that need attention. Because DAAs may be excreted renally, dose adjustments may be needed to be considered for DAAs, particularly regimens that contain sofosbuvir. Mild to moderate impairment is not usually a concern. However, if the patient has severe renal impairment or requires hemodialysis, then that requires treatment adjustments. The safety and efficacy of sofosbuvir-based regimens have not been established in patients with eGFR less than 30 or those with end-stage renal disease requiring hemodialysis. For these patients with an eGFR less than 30, Viekira or Zepatier are recommended for genotypes 1 and 4. However, for Viekira and Zepatier, we cannot use it in those with decompensated cirrhosis. For genotypes 2, 3, 5, and 6, those are recommended treatment is interferon and ribavirin if these patients have an eGFR less than 30. Patients with decompensated cirrhosis should be referred to a specialist. Usually ribavirin will be added to the regimens with the DAAs. However, if the patient cannot tolerate ribavirin, then we should probably extend treatment to 24 weeks. All right, should we go with the takeaways? So some key takeaways from this webinar. Many people living with ACV are unaware that they have ACV, therefore clinicians are responsible for knowing the risk factors and initiating dialogues about screening. As far as treatment, interferon-based therapies are no longer preferred, and new DAAs or direct-acting antiviral in pill form are the preferred treatments. Essentially, all patients with hepatitis C should be treated. However, cost, access, and provider willingness are all barriers to care. Therefore, clinicians should make strides to ensure equitable access to care. And lastly, special patient populations may require different treatments.
Great. Thank you so much for that excellent presentation. Thanks again, Austin and Jenna, for joining us today. Before our participants exit this video, I would like them to note the following. A copy of the slides from this webinar can be downloaded from core.arhp.org. As a reminder, you will receive an email from ARHP's Education Department in about an hour containing a link to the post-test survey. Your CME or Nursing CE certificate will be generated at the end of that survey. Be sure to print the certificate before closing the internet browser. If you have questions, please email us at education@arhp.org. Thank you again for taking the time to view this webinar. We hope you will take part in other live and on-demand activities hosted by ARHP.